Hi, and welcome to the basic cardiac ultrasound module number 2. We're going to talk about the apical views, subcostal views, and IVC. So the objectives today first are to identify the proper probe and settings for these cardiac views, positioning the patient appropriately for these views, and understanding some of the anatomy and landmarks and how to troubleshoot a poor view to make it better. So first, you're going to be using the phased array or cardiac transducer. Here is a good apical view, and you can see that this transducer has a very narrow footprint in that it can go in between the two ribs as pictured there over on the left. Make sure you put the machine settings to cardiac, and you'll notice the probe marker gets flipped over to the right side of the screen in the cardiac view. Now, pictured above on the left here, you can see two of the transducers we commonly use, phased array, both with the sonocytes and the Philips Lumify, but the butterfly is all three probes in one, so that's merely just want to change the settings to cardiac and becomes a phased array transducer. In the middle are linear transducers, and over to the right is a curvilinear or abdominal probe. So here's just a review of the views you got earlier, the parasternal long axis and the parasternal short axis. What we're going to get is over on the right, the apical and subcostal views. First, here's the apical view with a left ventricle there on the right upper side of the screen, left atrium below that, right atrium, and right ventricle. In between the right ventricle and right atrium, of course, is the tricuspid valve seen here and the mitral valve on the left side of the heart. Now, in the subcostal view, you'll see the RV there just below the liver, which you're going to use for the acoustic window, the LV below that, the RA above onto the left, and the LA below to the left. Now, first, in positioning the patient, you want to have them slide over to the side of the bed if they can and position on their left side. This brings the heart against the chest wall and also lets your probe get down low enough to get this view. Keep the probe marker pointing to the patient's left and left axilla. We usually start by just going in circles here, going round and round, trying to find that view. Here's another view. In the apical position, you'll see just below the nipple. If you can find the PMI, that's often a very good position to find this in. Here's another review just of the anatomy again. You'll also see there to identify the chambers on the right ventricle, you'll see a little band of tissue called the moderator band. That helps you identify the right ventricle. Make sure your probe marker is positioned correctly. You'll also notice that the left ventricle is also the long ventricle, that the mitral valve annulus takes off just a little bit below the tricuspid valve annulus. And in this view, you can compare the chamber size and function, get a good eyeball for the left ventricular ejection fraction. You can also make sure the right ventricle is 2/3 the size of the left ventricle or less. If it's bigger than that, there's usually left ventricular enlargement. You can also look at the RV function by looking right at the tricuspid valve annulus, and you can calculate a TAPSE. So that motion going up and down should be about 1.7 centimeters or greater, indicating a good right ventricular function. Again, the probe marker here is pointing to the patient's left axilla, not the right side, as in many other functions of ultrasound. The heart is unique here. If you can feel the PMI, that's a great place to start to get your view in the apex, and then just circles around that area. Or sometimes I just go below the rim of the breast. You'll often find the good apical view there. So here we're just going in circles, looking for that view. Here again is a review of the anatomy that we want to get. Now, sometimes you'll see that the septum is not perpendicular. And what you need to do here when you get this view is just make sure you rock your probe to make sure that septum is going directly up and down in the screen as it is now over in this area. Another common mistake is to get the aortic valve in view here by the star. And how you fix that is just merely to tilt the tail of the probe up, so the beam down, and you'll get rid of that aortic valve. That's more of an advanced view. We can do that later, but here you just want to get the full 4 chambers. Another common mistake we see is called apical foreshortening. And you'll see the image on the left ventricle looks kind of bullet-shaped. That's what we're looking for. On the right, the whole heart is more of a globe or like a ball, and that is a foreshortened heart. So here, if you foreshorten the heart, you usually have your probe up here, and you need to move it down to the apex to get that good apical 4-chamber view. Now moving on to the subcostal or subxyphoid view. Make sure the probe marker is to the patient's left. Here you're going to use the liver as the acoustic window. So you're going to need to increase your depth a little bit while doing this view. You're also going to have the patient bend their legs, and sometimes it's good to have them take a deep breath and hold it if you're not getting a good view, because that helps bring the heart down towards your probe. As you can see over to the right, a deep breath just brings that heart down and almost touches the probe. You also need to change your grip, and we'll show you that. You want to grip above the probe because you're actually going to be pushing down to the patient's abdomen and then looking up into their chest, almost like you're a surgeon going into their abdomen and shining the beam up into the chest. This is a really good view to get in a code 99 or code blue situation, because they can be doing CPR, and just in the couple seconds that they'll change providers, you get a good view of the heart. You can identify a lot of problems which can cause especially PEA arrests, such as cardiac tamponade. It's also a really good view in COPD patients. When they have a barrel chest, you often are not able to get those other views well, and this is the best view you're going to get sometimes. Also a very good view to identify pericardial effusions. So here's kind of what the anatomy looks like, again, to review that. And then here we're having the patient bend their knees, soften up that abdomen. I'm changing my grip, holding it above the probe. Now my fingers are all above the probe. I'm pressing into their abdomen. I usually caution them this is going to be a little uncomfortable, but it shouldn't be painful. Let me know if it's going to be painful. And now he can take a deep breath and get me a better view if he needs to. Again, here's another depiction from the other side. They're pushing the probe down into the chest, and this is the view we're going to get. Now to get the IVC, what you simply do is slide over the patient's right and then twist the probe. And as you twist, you should come right onto the IVC if you had the right atrium in the middle of the screen. So when you get that subcostal view, slide over to the right to where the atrium is in the middle of the screen, and then twist the probe, and you'll twist onto the IVC. Here's another depiction here in this video, just showing where the beam is and how it's cutting the IVC. You can see it go right into the RA. You should see it going through the liver, and you always want to measure the IVC from above to get a true diameter. It's kind of a flattened vessel, so if you look from the side, you're going to see what is a falsely dilated IVC. It's really the direct diameter measured from the top of the IVC down to the bottom. The other important thing is to make sure you get the hepatic vein in view here that confirms that it's the IVC. You can also look around the area. If you slide a little bit over to the patient's left, you should see the aorta there if you're truly on the IVC, and you do not want to make a mistake and be on the aorta thinking it's a dilated IVC. Again, here's another depiction how you're holding the probe, what the IVC looks like. If you're on the true diameter, you should get a bright wall on both sides because it reflects that echo very well. And again, you can see this vessel coming down here, which is confirming it's the IVC, and that vessel is the hepatic vein. Another depiction of the IVC here, nice and dilated, just partially collapsing. You can measure that. And here's a fully collapsing IVC with respiration. So if the patient on the right was hypotensive, they probably would still be fluid tolerant, is how we use this. It's a surrogate for the right atrial pressure. So the right atrial pressures with the patient on the right are not high, and they would probably benefit from fluids if they're hypotensive. Another way to identify the right-sided pressure that's probably better than using the IVC is actually the ultrasound JVD. So you just put a linear probe on the neck and identify the carotid and the IJ there. And when the IJ, you just slide up to where it gets as small as the carotid, and then that estimates your right atrial pressure. We can review that and other functions on rounds, and don't forget to look at the video in this series about probe marker positioning and review it. You start with it pointed to the right, and then the rest of the cardiac exam is merely on the patient's left until you get to the IVC.